Well, you know, it's funny, I use DCO all the time in the work that I do, and I've never used DCO quite like this. This is DCO on steroids for me. And for a minute there, I felt like I was playing a game of Simon Says. So what I'm going to talk to you about today is what right looks like with PCMH IMIT and what your role is. And I'm sorry that the title of this slide doesn't reflect that, but I think that the content in the presentation will. Just as by way of introduction, I'm a family physician, and I had my comeuppance at Brooke Army Medical Center, where I worked as a family physician, staff family physician on active duty for several years, and then became a Department of the Army civilian, and eventually worked my way up through the organization, ultimately to department chief for family medicine, and then left in December of 2010 to work for the AMEDD CIO on patient-centered medical home technology development and development of patient-centered health IT. I am also the Army lead on the Tri-Service Workflow team, and my official title used to be physician advisor to the CIO, and now I've moved into a capability management role. And so I spend all my time working on health IT related to delivery of patient-centered care and in support of patient-centered medical home, and I am IMIT representative, one of two IMIT representatives to the So just the objective slide here. Don't want to spend a lot of time on that. I wanted to first begin by talking about the notion of patient-centered health IT. It should come as no surprise that historically our IMIT development and investment process has not really been tightly linked with the delivery of patient-centered care or patient-centered initiatives. And if you've ever used Alta, you know that's the case. The patient-centered model of care really is fundamental to patient-centered medical home. When we think of patient-centered medical home, we often think of what we're doing with primary care, but it's really about the patient and all the things that we do in the care delivery process and inside and across our complex healthcare organizations to take care of the patient. So health IT really should enable the delivery of coordinated, integrated, and patient-centered care no matter where the patient touches the healthcare system. So it's not really just about primary care, although there is tremendous focus on primary care because that is the portal of entry and the front door, if you will, to the healthcare system for most of our patients, where they're going to get most of the more important services that will keep them healthy. And so modern technology really is a critical component to this patient-centered model of care delivery. If you think about the Surgeon General's presentation at the MHS conference this year, in which she talked about the white space, which she's now calling the life space, how do we penetrate the life space of our patients during those 550,000 hours per year when they are not interacting with the healthcare system and they need to manage their own care. And a lot of this comes down to virtual health solutions in terms of using mobile technology, telehealth, secure messaging, all kinds of things, and many, many other things that enable patient-centered care. I just saw. Keep going. Just making sure I'm not talking to myself. So in the process of developing this concept of patient-centered health IT, we've worked through a lot of issues that have confounded us in the health IT environment for many, many years. And we're really beginning to break down stovepipes. We're really beginning to work together collaboratively. We've developed a tri-service, cross-functional group of collaborators working on this concept of patient-centered health IT. We've really done due diligence in defining what the true functional requirements are to support and enable patient-centered care. We are definitely adhering to the MHS's guiding principles for IMIT development, and I'll explain those in a moment. And we are working very hard to integrate these efforts with the long-term plan of the development of the IEHR, so that we don't have to throw everything away and start over again when the IEHR is released. So here are the official published guiding principles for IMIT development in the MHS. Everything should be joint first with a common architecture, so no more pet projects, no more silos and stovepipes. And when I say joint, I'm talking about interagency, not just tri-service. So across VA and DoD, we're really working towards a common architecture. The concept of, we don't have to create the wheel ourselves every single time we need something new, every time we have a gap that needs to be filled, so we can adopt or buy as well. This notion of transparent and accountable management, so that we have a governance process that works. That's the goal. I'm not saying we're there. That IT needs to be driven by our strategy. And so, first we have to know what that strategy is and what our priorities are, what are our strategic initiatives, and then the IT needs to enable us to achieve those strategic goals. We need to be more agile in our speed to market, and we need to make sure that it's the true requirements that we have defined that are driving solutions, and not just the, pursuing the shiny object type of phenomenon. So in the development of our requirements to enable patient-centered care and PCMH, this started with the AMEDD back in 2010, and what we did was we used the emerging 2011 goals for NCQA recognition, because NCQA recognition is what the MHS has adopted as the method to develop or to identify standards for patient-centered medical home. In other words, how do we know when we are a patient-centered medical home, and what are our standards for achieving that? And so the strategic goals really are designed to enable us to achieve the strategic priorities of the quadruple aim through increasing patient-centeredness, aligning processes and requirements that improve quality, eliminate waste. So, becoming a lean organization, and increasing standardization, emphasis on patient feedback, enhanced use of clinical performance measures, integrating health, and enhanced coordination of care. And then the requirements are those 6 standards of NCQA recognition that focus on access to care, continuity of care, a population health approach to care, being proactive instead of reactive, planning and managing care, ensuring that our patients know how to self-manage their care while they're in the life space, tracking and coordinating care so that our patients don't have to struggle and flail as they try to move through the complex, fragmented healthcare organization, and then making sure that we know how well we're doing and relentlessly pursuing performance improvement. So I'm a strong believer that we're not achieving less than optimal outcomes in the AMEDD or in the MHS. That's not because we have a bunch of bad people. We have, I think, a bunch of wonderful, very talented, committed, passionate people in the MHS and specifically within the AMEDD. But we're not getting the outcomes that we'd like to see because, frankly, I don't know what your experience has been, but in my personal experience, many days it is very hard to achieve the right thing, and it's an uphill battle. And so how do we make right easy? Well, it starts with setting up the right system. So, we're talking about having the right policies in place, the right processes in place, the right talent, the right mix of personnel, people who can definitively say they are fully trained and competent to do their jobs. Standardization plays a role here. So, setting up the foundation for making right easy really requires having the right system to begin with. And if you place the right IMIT enablers that are driven by strategy into that right system, really, by design, get the right behavior out of your people and achieve the right outcome. So at some point you have to say it's time to stop trying harder all the time and try something different. And so that's what we're hoping to achieve with patient-centered medical home and with patient-centered health IT, is achieving the strategic goals of the quadruple aim by design. So now I want to move into talking about the patient-centered high-level functional requirements, or HLFRs as we lovingly call them. And in the development of these HLFRs, the goal was really to shape the development of MHS IT to support our transformation to a patient-centered healthcare organization, and thereby achieve the quad aim and NCQA recognition by design. So making the right thing to do, the easy thing to do. The process that we followed was by beginning with a multi-stakeholder group inside the AMEDD to do workflow mapping that really defined the ideal patient-centered care delivery process. And then we looked for in those processes where we could insert IM and IT to enable the efficiency and effectiveness of those processes. So again, this required broad functional coordination. Once we finished that inside the AMEDD, we took it to our sister services and validated the list of HLFRs in the Air Force and the Navy. And then we conducted a gap analysis and prioritized those HLFRs. And the ultimate deliverable was a list of 17 high-level functional requirements to enable patient-centered care. So these are the proposed technical approaches to help us do the right thing and achieve the quad aim and become a patient-centered healthcare organization by design. We have now established a tri-service patient-centered IMIT sub-working group that is organized under the Patient-Centered Medical Home Advisory Board at TMA. So again, it represents all three services plus JTF CatMed, and meets regularly, is tightly linked with the clinical leads for patient-centered medical home and patient-centered care. So in the Army, that's Colonel Mark Reeves, Lieutenant Colonel Tim Caffrey, and Lieutenant Colonel Corinne Devlin. And the responsibilities of this group are the validation of those HLFRs, improving coordination with the service CIOs and CMIOs. So once again, breaking down those silos and those barriers and trying to do a better job of linking IMIT development to patient-centered initiatives. And then making sure that our investments follow joint governance principles and are based on clinical requirements, not somebody's bright idea. That we are increasing standardization, reducing redundancy of pet projects and investments and tool development and everything else across the services. If there are capabilities that we no longer need to invest in, then we're going to work on sunsetting those if they don't meet the requirements of patient-centered care. And then again, delivering this common architecture that's integrated with the IEHR to ease the transition. So this is just a screenshot. We've got lots and lots of artifacts available on the MEDC website. And so there are 5 different cross-functional diagrams and use cases for various scenarios of patient-centered care delivery. You see down here at the bottom, there is a cross-functional diagram and use case for the PCMH team huddle. So there are several of these, and this is just an example of the one for the team huddle. And so lots of people and processes involved here, and then of course the systems integration in that second layer from the bottom. What are the systems that we would be using as these processes are occurring? And then on the bottom layer, what are the data integration and system exchange elements that are involved in these processes? So it's not meant for you to be able to read this. This is just an example of some very diligent work and meticulous work that was done by a broad group of stakeholders involving not just doctors and nurses, but administrative folks and workflow analysts, and then of course we also staffed this across all three services. We staffed it with behavioral health experts, with pain experts, really broad group of stakeholders to get to this final model. And from that came the list of functional requirements. This is just a snapshot of part of it. There's over 70 functional requirements, and the proposed technical approach is really where those HLFRs come to play. And so when you boil it all down, what you get, and I hope that your slides don't look a little garbled like mine do. That's unfortunate. I'm not sure what happened, but anyway, what you get is a list of 17 high-level functional requirements, and then we work together across the services to determine is this an AMEDD requirement or is this really a tri-service requirement? Nearly all of them have been confirmed to be tri-service. And then we conducted a gap analysis to say, where do we have enterprise solutions that are fully deployed and fully meet all of the requirements? Where do we have enterprise solutions that partially meet the requirements? And where do we have gaps that there are no enterprise solutions at all? So you see that there is no green on that list, unfortunately, so we've got plenty of work to do. No shortage of meaningful work. And here's the priority list. So what we did was we used a scoring matrix that looked at time to development and value to the organization. And all three services and JTF CapMed partnered with their functional leads to determine what the priority was for them for each of these capabilities. And ideally, we would first invest in and develop things that are in the priority 1 category, and last invest in and develop things that are in the priority 9 category. I'm not saying that's what's happening, but that's what we're pushing for. So, for some reason you can't see the diagram, I guess, of the joint governance, but the point of this slide is to say that all of those high-level functional requirements have been submitted into the joint governance process as of April 2012, which was when joint governance was stood up. So the minute we started joint governance, we put those high-level functional requirements in there. So we're trying to get through the analysis of all those requirements and move into investment and development stage as soon as possible. So, pardon me. Now I'm going to talk about what we have today in the PCMH IMIT portfolio. I do not expect that anything in here is going to come as a big surprise or news to you, but I do want to make sure that we are all tracking the same items. If I've left any out that you think are important IMIT enablers, I'd love to hear about those. And so, these are what we're focusing on here are things that are available as enterprise solutions. So, not local pilot projects, but things that everybody can use. And then, where we're going in the future. So, let's start by talking about ALTA. And I put that picture of Yoda up there because, as we know, the way that ALTA likes to deliver encounter documentation can be very garbled. And in fact, many of the data elements that we look for regarding a patient in ALTA are fragmented in various places. Sometimes you're hunting for a piece of important information like a needle in a haystack. And all of this can be very burdensome in the clinical workflow. The encounter workflow alone can sort of be all over the map in terms of the patient's needs and the things that what the patient presents to us is what they need, the things that we think the patient needs. The discussion can wander all over the place, and the note can be ultimately a mess as well. And in the midst of all that, we work very hard to try to hit the target and make sure that we're taking good care of our patients. But it often winds up being very frustrating for the patient. Despite our best efforts, our patients are not getting their needs met fully. And it results in a lot of frustration for our providers as well. So, when it comes to what we can do with what we have today, we have to think outside the box and look for ways to make ALTA work to our best advantage. And with ALTA and with many other things across the MHS and across the AMEDD, we really could take advantage a great deal of more standardization, because the standardization helps us reduce the chaos, helps us reduce the unpredictability, helps us reduce waste in our system, and therefore reduce the frustration and help us get to a better result. So I don't know about you, but when I think of standardization, I think of MAPS 2.0 and Tri-Service Workflow. Again, I'm the Army lead on the Tri-Service Workflow team and work closely with our MAPS folks. And so, of course, Tri-Service Workflow is a part of the MAPS 2.0 program. Important piece of workflow standardization in the MHS. The mission of Tri-Service Workflow is to provide clinical workflow solutions, leveraging evidence-based practice and bringing best evidence right into the point of care, making that part of the care delivery process, bringing other pieces of technology together and integrating those into the care delivery process, and then providing curriculum development and training for users all across the MHS. So it's a lot of people think of Tri-Service Workflows as an AIM-form product, and it's so much more than that. If you know anything about it, you know that it's not just a documentation tool. There are processes and other technologies involved in Tri-Service Workflow, and although we do provide a lot of AIM-form development and AIM-form products, that's just sort of part of the whole package. So unless you're a brand new hire or you've been living under a rock for the past year, you no doubt find this screenshot very familiar. And so this is the screenshot of the top of the first tab of the Tri-Service Workflow Core AIM form, which is intended to launch every adult encounter, outpatient encounter across the MHS in primary care. And then the MAPS tools are what we use to facilitate input and improve quality of documentation so we can get through our day better and create better notes. I want to make sure I call your attention to these buttons up here. The top one is the one that's most important for me, Tri-Service Workflow Resources and Feedback. So any user can click on that button anywhere in the MHS. And what you get when you click on that button is access to the Tri-Service Workflow Millbook site, where we have many resources available, and customers can post their feedback and input and have discussion groups about workflow issues, about ALTA Tier 1 errors, about recommendations for Tri-Service Workflow product improvement, and our team reviews this input and constantly uses that customer feedback to improve our products. And it's a direct feedback loop that gets real results in real time, and we're real proud of that. So if you haven't taken advantage of that opportunity, please do, and please make sure that when you are training this to clinical users, that they are aware of that opportunity, and let them know that we really do respond to customers through that website. This is also included in the website. It's we've got lots of training tools available to help support tri-service workflow training. And then, the ultimate point of this is that in a complex outpatient clinical environment where we've got lots of people taking on lots of new roles and responsibilities, the ultimate intent is to get to a comprehensive care experience for our patients. So this is a list of tri-service workflow products. Currently deployed, we have much more than just the core AIM form that I just showed you. There's a whole family of PEDS AIM forms, and there's a tri-service workflow procedure AIM form. There's a low back pain, that should say CPG AIM form that's been deployed, and there's a behavioral health specialty AIM form. Now, we've really only focused on our training with the core AIM form, but there's so much more to be gained by using the full complement of tri-service workflow products out there, and I think we need to start to expand our training portfolio and providing training for these other products and making them available so that everyone can take advantage of them. Then in beta testing, soon to be fully deployed are the pulmonary CPG AIM form and the metabolic CPG AIM form to help support evidence-based disease management of those types of diseases. And then currently in development and soon to move into beta testing are the substance use disorder CPG AIM form, the geriatric AIM form, the OB CPG AIM form, and a new nurse tech AIM form to help cover 85 to 90% of the work that nurses and technicians are doing in the PCMH, and a case management AIM form. And then we're also working on a tool to help deliver a comprehensive care plan that can be documented in Alta, and then also provide a patient-facing version of the comprehensive care plan. That'll be web-based. Obviously, there's a significant training burden with all of this, not just with the tri-service workflow products, but we're talking about, clinical users. You saw the list of high-level functional requirements, and as we push out things like secure messaging and mobile technology and queuing and kiosk technology and telehealth and all these things, the folks that are delivering care more and more are going to have to learn how to use a broad spectrum of technology to care for patients, because remember, we said that modern technology is critical to the patient-centered care delivery model, and technology penetrates every aspect of everything we do these days. So there's a significant training burden for those that are going to be using these tools, and therefore a significant training burden for those of us who will be providing the training for those tools. And we've got to figure out how to do that smart. So let's move on to secure messaging. This is the latest sexy tool that we're rolling out. Of course, this is MHS wide, so everybody's getting it. But what you see here is the newly published, as of this week, Operation Order 12-57 for implementation of Army Medicine Secure Messaging Service, or AMSMS as many people call it. So this just hit the street a couple days ago, and Army Secure Messaging will be a 3-year phased rollout. The first year is targeting primary care in every primary care venue that you can think of, the community-based clinics, the MTF-based clinics, the Soldier Center medical homes. And then in subsequent years, we'll be rolling this out to all subspecialty care. And the licensing is assigned 1 per PCM or 1 per subspecialist, and then those licenses cover the entire practice, including your central appointing clerks. The vendor provides the initial training and the workflow integration, and then our CWAs are doing additional workflow analysis to make sure that this really fits tightly into the workflow, and then documenting those workflows and sort of scouring the AMEDD for best practices and making sure that we share those. So you CWAs out there play a critical role in making sure that we get to making write easy with secure messaging. And then our systems trainers may serve as the super user, may serve as the clinic administrator, a sustainment trainer. These things will be locally determined, and all of this is defined in the op order, and then also in the Army Medicine Secure Messaging Service Guide. Both of those resources and other secure messaging resources are available on the ACE portal under the secure messaging. Okay, so TRICARE Online, before you roll your eyes, they are working on improving the access method, but I will say it took me 1.5 years to get access. It wasn't 1.5 years of 24 hours a day, 7 days a week trying, but it took me a good long time, and once you get access, it's actually a pretty useful tool. So of course you can book appointments online. The blue button gives you access to a lot of personal health data. It's not a PHR per se, but there's a lot of personal health data available there, so it helps us move towards transparency of health information. Of course, you can request prescription refills. You can't get renewals, but you can get refills, and get access to the secure messaging platform as well. So, certainly this is, we're not green when we look at the gap analysis for having a web portal, because this doesn't really get us all the way there. But it's a good start if you can get over the hump of getting access. This is the Army Patient-Centered Medical Home homepage on AKO, and so if you haven't been there, I encourage you to look for it on AKO and take a look at the resources there. There's all of the Army Patient-Centered Medical Home training materials available there, the outboards, and all the fragos. There are 4 fragos to the outboard now, if you didn't know that. There are resources in terms of NCQA recognition, and the medical home huddle video. If you haven't taken a look at that, it's about 8 minutes long, and it is priceless and gone viral globally. You wouldn't believe it. So that's a great resource for Army Patient-Centered Medical Home. So let's talk about the Population Health Portal and CHAS, also known as ICDB, because these really do bring some capabilities to bear that aren't perfect, but they definitely fill a void and help us achieve some of the NCQA standards. Population Health Portal provides action lists for patients with chronic conditions or preventive health service needs, and the direct care labs are updated nightly, so it's, if it's a service that was provided in the direct care system, you get that information pretty quickly. You can also locally enter exclusions so that you are not bugging patients who no longer need those services. And it's got HEDIS metric reporting that you can drill down all the way to providers. So it's important to know not just what the actionable information is, but how well you're performing. And the Pop Health Portal gives you that information. Gives you a patient detail view if you need to look up, the detailed status on a particular patient in terms of disease management or preventive services, etc. Gives you a high utilizer list. So lots of capabilities available on the Population Health Portal that not everyone has tapped into. And then CHAS, or ICDB, of course, will give you an appointment list, and you can look at by day, by week, by month. and it'll show you which appointments have been booked with PCM and which are not with the PCM, so that you can work on rearranging some of those. It also helps you with some transitions in care, so it shows you patients that were recently hospitalized or seen in the emergency department. Of course, those are only direct care hospitalizations or ED visits, but it's better than nothing. So, you know, if we're going to try to at least take a bite out of managing those transitions in care, that data is visible in ICDB. Another one of the standards is the ability to track labs, RADs, and consults, and that information is available in ICDB. A lot of people don't know that. We have the ability to view patient summaries, so, you know, get a very consolidated view of our patients in a way that we can never see in ALTA unless we, you know, construct it manually. It allows you to create lists and disease registries for patients who, you know, have certain conditions. You can also cross-reference those with other conditions, so show me all my diabetics who are obese type of thing, and then, you know, patients who are due for services, etc. And got a lot of other modules in there. So lots of potential in ICDB. Yes, it still has some fundamental flaws. I am very aware of those, and so at this point, you know, there are limitations, but I think that there are things in ICDB that we haven't fully taken advantage of because people just don't know that they're there, and we haven't helped them put it into the workflow. So, you know, a lot of this is just identifying whose role it is to review this information, and you know, how do they access it and what do they do with it. So I'm not going to review this, but I wanted to make this available for you later when you're reviewing the slides, as these comparison slides. And then I get a lot of questions about the data differences between ICDB and Pop Health Portal. ICDB is local CHCS host data, and it's near real time, so it's almost, you know, updated by the minute. And the only exception to that is the Proactive Patient Management module, or PPM, and that pulls data off of the same database as the Pop Health Portal. So it's the full complement of all CHCS hosts and M2, and that's refreshed monthly. So Pop Health Portal has data from all CHCS hosts and the network data, which is, you know, billing data out of M2. So you can see that a hemoglobin A1C was done, but you can't see the result because it's billing data in terms of the network part of the data. The lab results are updated nightly, and it only contains patients that are enrolled to the MTF, and in other words, you know, you can't see patients that are not enrolled to our system and to the direct care system. So the issue that we face now is that we've got one CarePoint platform, but two different CarePoint applications. And the reality is that CarePoint was set up on two different websites and not integrated into a single website. The first website was the Population Health Portal, which is an enterprise level version of CarePoint. And the second website was ICDB or CHAS, which is an MTF level CarePoint. And the future is that CarePoint 3G will contain both the Population Health Portal and an ICDB-like type of capability in addition to other new capabilities that we haven't seen before. And I'll cover the CarePoint 3G in just a minute. If you are not familiar with the command management system, you really ought to take a look in there. There's a lot of information in there that's very valuable in terms of performance reporting. And you know, the main limitation, at least for me, is that the data doesn't go down to 4th level MEPR. So you can get it down to DEMIS level, and you can get it down to child DEMIS level, which is very helpful for those outlying practices like the community-based medical homes, because that's basically practice level data. But it'll really be helpful when they get it down to the 4th level MEPR, which they are working on. Just wanted to point out that there's a MAPS report here. I'm sure you talked about that recently, but you can see MAPS performance data on the command management system, and it's not hard to get access. TRICARE Operations Center is another great source of information about PCM continuity, access to care, things like that. So for our practice managers who need our help too, you know, PCMH is not just about you know, what's happening in the exam room, not just about secure messaging, it's about practice management as well, and knowing how we're doing and being able to manage the practice. So TRICARE Operations Center and Command Management Systems, both useful for those practice managers. One of the NCQA standards that people get stumped by that is really easy to solve is the booking future appointments. And we can, of course, easily book future appointments in the practice before the patient leaves the practice if it's within that 45-day template window. But what do you do when patients are going to be seen 3 months from now? And the CHCS waitlist function is a great way to make sure that we are tracking those patients that need an appointment outside the 6-week rolling window. Now, in the past, the CHCS waitlist function has been abused and used for patients for whom we couldn't provide access today, even though they needed it today. So it was a bad backlog situation, and patients were piling up and couldn't get the care they needed. That is not the way to use the waitlist function. But it's very easy to use, and really helps us keep track of those patients who need to be seen 3 months from now, 6 months from now, a year from now, so that you know, it's almost like a tickler system, and it's very easy to set up those processes. So if you haven't helped your practices locally figure out how to use leverage the waitlist function, please look into it and help them, because this is one of those with a legacy system that will really help us be more proactive and appear to our patients much more patient-centered. So that's the current portfolio, and now I'm going to talk a little bit about work and development, so things that are in the pipeline. This is a screenshot of the new CarePoint 3G, and so if you scroll down, there's access to the population health portal and some other things there. There's not really anything new or of value to you in CarePoint 3G right now. They are still working on it. But it promises to have quite a lot of new technology that I think is really going to help us going forward. But it's going to be a while. They've still got quite a bit of work to do. But you can certainly go to their website, the carepoint.afms.mil, and see what that looks like. It will be single sign-on so that you can get to all the applications that you see in the Pop Health portal, all the applications that you see in ICDB, and a bunch of new stuff as well. This is the web-based CCP tool that I told you about, and so it's still in development. We don't even have a prototype to pilot yet, but it's intended to look something like this. It's being built under the umbrella of the Tri-Service Workflow team, and intended to partner with the Tri-Service Workflow products, and should help us do a better job of more efficiently building a comprehensive care plan for our patients. So a patient-facing version, and then also a version that can go into ALTA. Obviously, the ALTA version would be worded in medical technology, and the patient version would be much more lay terms and focused on the information that the patient needs to know. So that's in development. MEDCOM is developing an Army PCMH website to be used as a knowledge management platform, and this will be standardized at the headquarters level, at the RMC level, and all the way down to the MTF level. So no more everybody's sort of got their own version of a website. It's going to be a very standard format. So if you've ever looked at, for example, Kaiser Permanente's website, you can Google Kaiser Permanente And from their main homepage, you can drill all the way down into individual practices, and the look and feel of the website and the functionality and the capabilities are in very standardized format, although the information as you drill down is more and more customized and unique to local areas. So that is the way forward for the Army Medicine. So that's in development. Our business intelligence team has been working very, very hard for the past 2 years to support PCMH transformation. They have really scrubbed the NCQA standards and found that 80% of those standards require some level of business intelligence support. So discrete data elements that are required in order to enable those achievement of those standards. The current enterprise BI package really leverages strongly the Air Force platforms with Population Health Portal and ICDB CHAS. CHCS still gives us a lot of good information. That is business intelligence, the TRICARE Operations Center that I talked about. So that package addresses 19 of the top 36 priorities for business intelligence in support of PCMH transformation. So those working solutions are what I just shared with you. So that takes a chunk out of it. And in the meantime, we've been working on developing a PCMH team dashboard that will help serve up actionable information to those PCMH practices as they are preparing to conduct a huddle, as they are preparing for visits, as they are looking for patients with HEDIS care gaps, etc. So I just wanted to share with you some of the work that's been going. MEDCOM has partnered with Madigan, and we've already piloted phase 1 of this PCMH team dashboard. And so this is just a screenshot of the login page. And
no, ma'am,
can you
fine.
still see my screen? I didn't lose connectivity, did I? Okay, good.
No, ma'am, you're fine.
All right, thanks. And so the team dashboard looks like this. It's not that different from what you see in ICDB in the patient appointment module, except that it's color coded. So the colors that are green show where you've got PCM continuity versus red is someone who's not booked with their PCM. And then, open bookable appointments, which is something that ICDB doesn't show you, so that, where you can plug patients in. And then it shows the care needs and transition care, patients who were recently seen in the emergency room. Diabetes, etc. So this is really, I think, going to be a transformational tool once we figure out how to get it into an enterprise solution, and working very hard on that. Other PCMH IMIT in development. Mobile health solutions. Phase 1 of the ConOps has been approved by the Chief of Staff, so we're rolling forward with that. Telehealth has actually become its own service line, recently established under Health Policy and Services. There are multiple projects already in deployment for behavioral telehealth, derm telehealth, etc. And this is expected to really take on a life of its own. There's a personal health record working group that has been developed by TMA, and there's a charter established for this group, and they're charged with developing a personal health record capability ASAP. There are multiple pilot projects for queuing technology, kiosk capability, integrated communication tools. All of those are on the HLFR list, and we just don't have an enterprise solution selected yet, but we've got lots of pilot projects out there that are proving the value of these tools. So in summary, PCMH brings significant new technology with it, and all of this new technology inserted into the workflow is intended to enable this patient-centered care concept no matter where the patient touches the healthcare system. So again, this is not just about primary care. This is centered on the patient as they move through the healthcare system. And that means, you know, inside the direct care system, across out to the network, inpatient, outpatient, long-term care setting, everywhere. But of course, new IT brings new workflow issues, new behaviors in our employees and also in our patients, a huge burden of training, new troubles in the experience of care, and ideally our patients and those folks who are taking care of our patients, slugging it out in the trenches, will only experience the positive impact of all of this new health IT, and it's our job to solve those problems before they touch the patient. So I think that's really our role, is to understand how all this IT works and to help ensure that our folks understand how to use it, that it fits well into the workflow. And you know, it seems like a lot to have to manage if you're a trainer and you have to learn how to use so many tools. But if you think about the folks at the point of care who also have to learn how to use all those tools and use them effectively to take care of patients, important partnership there that we really need to make sure we take advantage of and help support those folks so that we can really become that patient-centered organization. So that concludes my briefing, and I am ready for questions.
As a reminder, I know some folks. I'm sorry, I'm getting a lot of feedback. As a reminder, I know some folks. Best if you write it in the chat box.
So I saw some questions popping up during the briefing, but I was following the rules and holding those till the end, but I don't know where they went.
Unfortunately, there was enough questions along the way. If we could go ahead and ask them again.
I see one here. Is there a plan to update the PEDS forms so they overlay each other and the front page should be the same on each one of them for screening and copy forward purposes? Okay, that's a very valid question. The answer is that we have been working very hard on the PEDS family of AIM forms, and we recognize that there is a lot of integration that needs to be done between and amongst those forms. We're closer than we were before. The new forms should be updated in the enterprise folder sometime in the next few weeks, and so those will be better versions than what we have out there now. They won't be perfect, but you know, so we're still going to have quite a bit of copy forward issues and obsolete terms that we have to get rid of. A lot of that sort of seems to focus on the anticipatory guidance requirements as we move through age groups. So from 0 to 23 months, from 2 to 6 years old, those types of things, the anticipatory guidance requirements change. And so some of that is sort of built into the process of using those forms, but processes are. So work in progress, but we definitely have identified that as an issue and are working on it. Here. Notifications prior to release of new TriService workflow forms, please. So we are doing our best to notify folks when there are new releases. We post that always on the MillSuite site, and then we push it out to the trainers and the CWAs through those communication chains. And we have recently decided to also keep an updated list of forms, current forms in deployment, and the most current version of the form in the toolbox tab of all of the AIM forms. So you won't see that just yet, but that will be coming very soon. That was a decision that was made last Friday to help give people a point of reference where they can find that type of information. So on the MilSuite site, and then of course through your CST and CWA chains, and then on the AIM forms themselves. So I hope that helps. We really, we worked hard at this knowledge management piece, but it just is difficult, as you all know. Oh, hey, now I have a nice big let's see. Gosh, I'm getting lost in all of this. Will we have the slides available on the ACE SharePoint site? I assume so. Prior to updating forms currently in use, can a notification be sent out to make aware of the changes we should expect? There's a change log in all of the forms. So when you see a form updated, you can go to the change log and it'll show you all the changes that were made to the form there. Could we please consider an AIM form for the ER? I know there's one currently in progress, but if we could have one, sites like Leonard Wood that are moving to the use of ALTA in the ED would be very helpful. Not a tri-service requirement. Most folks don't use ALTA in the ED, and so I doubt that that's going to be a tri-service workflow product, but I do know that Fort Sill was working on developing one, so you might talk to those folks and see if you like that product. What you were looking for is a tri-service workflow version that's compatible with the one used by primary care. Yeah, again, not a tri-service requirement, so I don't know how high that's going to land on the priority list, but certainly submit the request on the MilSuite site, and what info is on the MAPS report? Time to close records and continuity, and I forget, there's a whole list of sort of quality metrics that are supposed to be impacted by MAPS that show up in the report. How do we request access to the site or report? I'm not sure which site that was referring to, so maybe you can ask your question again. PCMH website is fantastic. Can't wait to hear how to access it. If you're referring to the one that is on AKO, then if you're an AKO user, then you can just log on to AKO and you can get to it. And I can certainly give people the URL. Are they going to use Relay Health, Personal Health Record, or developing a separate one? That's what the Tri-Service PHR working group is going to help decide. There are multiple options for a personal health record out there, and we just need to make an enterprise decision on which one we're going to pursue. And that's. Please ask questions now via chat. Is there a plan to update the PEDS forms? Oh, I answered that one. PT, OT, Tri-Service workflow forms coming out in the future. Yes, that is in the queue for new initiatives. At Leonard Wood, we are moving towards having our ED. I answered that one already. Asked us to develop the patient CCP encounter summary. You mentioned this being in development. Any idea how soon this will be available? I don't want to promise anything, make a promise that I can't keep, because it's not up to me. I'm not the software developer, and he's basically doing this for me at 2 a.m. in the morning, and so just bear with me. I'm trying to get it out as soon as I can. It's not hard work, it just takes time. Please change the pain scale and move the depression screening to the front. So depression screening is on the front page of the HPI, and the pain scale, I'm not sure if you're talking about the 0 to 10 or what the issue is. Maybe you can get with me offline about that. PPM module and CarePoint ever get to real-time data for statistical reporting purposes? So the data that is in the PPM module is comes from CarePoint Population Health Portal, and that data is updated nightly from the CHCS host, but the M2 data has a 30 to 60 day lag, and there's nothing we can do about that. And then what they put into PPM is updated once a month, and that's up to the Air Force. I can't tell you.
Excuse me, I know we're getting...
Excuse me, I know we're getting some great questions.